Hospital, Bangkok, Thailand. I'd like to thank Dr. Malay Sharma for the opportunity. Today, I will be speaking on how I do EUS FNAC. The basic things to consider when doing EUS FNA are, number one, aspiration techniques, such as how to select the target area, central versus peripheral versus throughout the lesion, speed of needle throw. There are some techniques have been described like door knocking and woodpecker, which I will touch on later, number of to and fro movements, number of passes, the use of stylage. Number two, suction techniques like standard suction, which requires 10 to 20 ml syringe with negative pressure, wet suction, slow pull, or no suction. Needle selection, we have different sizes of needles to choose from. Are they different? The aspiration versus biopsy needles, are these different? Finally, tissue processing, including ROSE, which is rapid on-site evaluation, MOSE, which is macroscopic on-site evaluation, and cytology and histology preparation. Let's start with aspiration method. Fanning technique allows tissue acquisition from throughout the lesion. And here's the video demonstrating the fanning technique. And here's a target lesion with the fanning technique. The needle trajectory aims at different area throughout the lesion. And you can see that the needle is puncturing through a random area depending on how you control the needle. And to achieve this technique, you can do it by controlling the big wheel in order to bring the needle up and down, or you can use the elevator as well to direct the needle trajectories. However, I would avoid using too much of the elevator because it may bend your needle. A randomized control trial demonstrated that with the fanning technique, it provides better first pass diagnosis compared to standard technique without needle dysfunction. The percentage of first pass diagnosis you would gain from fanning technique is about 85.7% compared to 57% from standard technique. Door knocking method is advancing the needle in quickly, allowing the handle to hit the stopper, creating a door knocking sound, and pull back slowly during the stroke. The woodpecker technique requires moving needle finely and rapidly in the lesion. It is good for a small lesion of less than 1 centimeter. A prospective study from Japan comparing the door knocking method to conventional technique for pancreatic masses has shown that the door knocking method provides better cellularity, but no differences in the diagnostic accuracy. In terms of number of passes, most studies show that 3 to 4 passes are required to obtain diagnosis with 22 and 25 gauge FNA needles, whereas only 2 to 3 passes are needed with F&B needle. Moving on to suction method, 4 RCTs have been performed to compare suction versus no suction using 22 and 25 gauge FNA needle. 3 out of 4 studies show that suction increases the sensitivity and the diagnostic accuracy. However, it also increases the blood contamination in some studies. In terms of wet suction, 2 randomized controlled trials comparing wet suction with standard suction using 22 gauge FNA needle And the results show that wet suction provides better accuracy, higher tissue adequacy and cellularity with less blood contamination. In one of the studies by Wang, show that only 2 passes required for non-pancreatic lesion using wet suction with no rose. In terms of stylet slow pull technique, a multi-center randomized control trial comparing slow pull versus standard suction showed that both techniques provide comparable diagnostic accuracy with 22 gauge FNA needles. Only 2 passes were required. And this video shows you the slow pull technique. And this is how the slow pull technique is being done. You have your nurse assistant pulling back the stylus slowly as you are performing the aspiration. And again, the fanning technique is applying right here. Now, based on the current literature, fanning technique provides better first pass diagnosis that's based on one randomized control trial. 3 to 4 passes may be required for FNA without rose, and the use of stylet is not necessary as it does not provide any differences in terms of tissue adequacy and quality, and that is based on 4 RCTs. And in terms of suction, standard suction gives you better yield than no suction that's based on RCT. The wet suction and stylet slow pull appear to be effective as well. So really based on this level of evidence, I would say the fanning technique is recommended. 3 to 4 passes may be needed for aspiration if no rose is present. And the stylet is probably not needed. Standard suction can be applied. It's proven to be helpful. In terms of wet suction and slow pull, the data look quite good, but I think this is going to be up to the endosonographer preferences, whether or not they like to use this techniques. Now, moving next to needle selection, based on 9 RCTs and 5 meta-analysis, 22 gauge and 25 gauge are comparable in terms of diagnostic performance. I will not touch too much on the details of the biopsy needles today, but what I want to show you is this largest meta-analysis to date, comparing the FNA versus FNB needles for solid lesion. The results of this study show that FNB needle is superior to FNA in all outcomes, including diagnostic accuracy, tissue core rate, and it requires less passes. And this study included 18 RCTs with the number of patients over 2,000, and all of the biopsy needles were performed with pro-core needles. These results are applicable for pancreatic and non-pancreatic masses. Lastly, tissue processing. Traditionally, rose had the biggest impact with increased diagnostic accuracy and decreased needle passes. However, recent data show that rose does not affect the results of FNA in large volume centers. Recently, MOS has been introduced to the field. MOS is a macroscopic on-site evaluation of the tissue, and it's been shown that the tissue length of more than 4 millimeters has been indicative of tissue adequacy, and the role of MOS has been evaluated. This is a randomized control trial comparing MOS versus no MOS, meaning just the conventional FNA in the absence of rose. Only 19 gauge needles were used in this study. The results show that MOS provides comparable diagnostic accuracy but fewer passes compared to conventional FNA in the absence of rose. Besides from cytology, the tissue should be prepared for histology using cell blocks. In my practice, I fixed the tissue in formalin and later paraffin embedded. This technique provides histological examination and ancillary studies. We have demonstrated that the combination of histology and cytology assessment provides better diagnostic yield compared to either one alone, as demonstrated here. The sensitivity of the combination of the two methods improved from 68 to 74, and the sensitivity remained high at 96, with the AUROZ improved from 0.80 to 0.85. And therefore, the combination of histology and cytology is recommended for tissue processing. I just want to show you here, before I finish, a video of how I perform an EUS FNAC. So starting with inserting the FNA needle through the working channel, and you want to tighten up the needle, and after the needle is locked, then you make sure that the sheath is out of the scope to prevent scope damage when you pass the needle. Then the stopper is unlocked, and we are going to use Doppler at this point to make sure that there are no intervening vessels in the needle passage. Once we confirm that, we can pull back the stylet a little bit and advance the needle in. And if you're going to use suction here, you can remove the stylet altogether and attach the needle with the suction. But if you're going to do slow pull technique, you can have your nurse slowly pull back the stylet as you are doing the aspiration. For this video, we are going to demonstrate suction. I only use 5 ml of suction, and once you attach the suction to the needle, the suction can be open. And the aspiration is performed. Again, we like to do a fanning technique to make sure that we get the tissue from throughout the lesion. And after the aspiration is done, then we retrieve the tissue like this. We are preparing slides for cytology smears, as well as formalin for cell block. So once we get the needle out, we like to expel the material by using stylet. We push the stylet back into the needle, and that way we can expel the materials onto the glass slide and prepare for cytology and histology. Finally, I'd like to conclude that the way I do EUS FNAC is that the needle selection is customized depending on the lesion. I always apply fanning technique. The aspiration techniques, whether or not I use the door knocking or woodpecker, would depend on the nature of the lesion. I always apply slow pull. The suction may be added if no materials observed in the aspirates. And finally, tissue processing, which I think as important as the aspiration techniques. We have no rows, therefore I always do macroscopic on-site evaluation of the tissue, looking for core tissue. And I also prepare cytology smears as well as cell blocks for histology. And with that, I would like to thank you very much for your attention, and I will be happy to answer any questions. And I want to wish you all well and stay safe during this pandemic. Thank you very much.